Good afternoon, sir.
Sir, कैसे हो sir? Good afternoon. Am I
afternoon.
audible?
Yeah. Can you share the screen?
Yeah, I will share the screen and I will let you know with the first.
Okay.
Is it visible?
Yeah, visible.
Yeah. So should I?
Slides are moving. Are they moving?
Yeah.
Yeah.
Good afternoon, sir.
Yeah, it's fine, sir. You can stop sharing.
Okay. Chalo, check
Good
and found
afternoon,
correct.
Vamshi.
Good afternoon, sir.
Good afternoon, Vamshi.
कोई बैकग्राउंड में आवाज आ रहा है सर काफी. हाँ, अभी बंद हो गया.
We'll start at 2 p.m., sir, exactly.
Okay, sir. Sir, as you suggested yesterday, today first program would be Piali Madam, sir.
Madam
PL
is in
madam.
airport. She said she will join at 2:30 after the Maratha stop.
Marathi, sir. Okay, sir.
Hi, Sagar.
Good afternoon, everyone.
You are
Good
muted
afternoon,
yourself.
sir. Good afternoon, sir. Sagar, sir.
Good
Sanjay, sir.
Good afternoon, everybody.
Hello. Good afternoon, Surendra sir. Good afternoon, Sanjay Marathi
Good
sir.
afternoon. Good afternoon.
Yes, good afternoon.
Yesterday we had a very good session.
Yeah, I read in this that group.
And there was no hitch anywhere.
Yeah,
Quite smoothly.
some sound is
Because this-
continuously coming. Now it has stopped. No, it's still coming. Somebody might have joined with two telephones simultaneously.
Vamshi closed. Now it is not coming. Okay. 1 minute is left. I think we can start.
No, the first lecture will be taken by Dr. Piyali madam, isn't it?
Madam said she will join at 2:30 after Sanjay's stop.
Okay, fair enough.
I have to slides I will be presenting. She will be talking.
Okay.
I kept it ready.
Today there is all this Ganpati programs and so much music and sound
Yes,
around
yes.
me. I've tried to pack myself in. I don't know. I hope so that during my lecture no one makes the sound. Otherwise, can't help.
You can go for that moon dress Neil Armstrong used to wear.
and take my laptop also inside.
But good news is that you are expecting heavy rains in next 3-4 days. So Marathwada people should be very happy.
It was raining heavily in last 5-7 days also.
Yeah, I just heard that 3-4 days are having orange alert. That's a good news.
We are happy with all alerts. Okay, so the recording has started, and I think so we can start the day 3 session of our issues in vaccinology session.
Yeah.
Dr. Vamshi, should we start?
Yes, sir. A very warm welcome to all the speakers and delegates who have come, and it's been a successful program last 2 days, and especially yesterday's being a very successful interactive session. Dr. Sagar sir ensured, and Surendranath sir was excellent in making everybody feel comfortable and going in this journey of vaccination issues, national module. I thank once again on this moment the Central IAP President Kunjuwadekar sir, Upender Kunjuwadekar sir, and Secretary Saxena sir, Vinit Saxena sir, and Surendranath sir. A special thanks to you, sir, and Sagar Kulkarni sir, who has done an excellent job, and all the faculty yesterday, Evale sir, Vijay Evale sir, and other faculty who enabled Jaydeep Chaudhary sir, and our moderator Surendranath sir, and Ganesh Kulkarni, and our President-elect Basuraj sir. An excellent talk he has given. And on the first day, we saw Indrashekar Rao sir, Sanjay Srirampuri sir giving an excellent lecture along with Rajshekar sir and Surendranath sir being moderating along with Srinivas Kalyani. And I take this opportunity to invite all the faculty and the members to come and join, and please allow to your friends also to join and make this program very grand success. This vaccination module being IAP President's Action Plan program. On day 3, we will be talking about influenza, rabies, HPV, newer vaccines, and vaccinations in special situations, AEFI anaphylaxis by Sanjay Marathe sir, Sagar Kulkarni sir, Abhaisha sir, and then we have Piali Bhattacharya madam, who is Vice President of Central Zone. Thank you. Over to you, sir. Thank you, sir. Please, Sagar Kulkarni sir.
Yeah, so I welcome Dr. Sanjay Marathe sir for his first lecture on influenza and rabies vaccine.
Should I go ahead?
Yeah, please.
Am I audible and visible?
Audible and visible. Your bandwidth is little bit low. If any issue occurs, you will have to stop your video but continue giving the lecture.
Absolutely. Good afternoon, everybody, and it's my pleasure to be a part of this wonderful workshop. So thankful to the Central IAP headed by President and the scientific committee who has come out with such a beautiful workshop, and they are being conducted all across the India. I'm equally thankful to TCB workshop committee and my friend Dr. Surendranath for giving me an opportunity. Today being the opening batsman, two important vaccines we are going to discuss: influenza and rabies. Influenza, the disease from the virus from the orthomyxovirus, such an important disease responsible for a huge disease burden across the globe, and our country is not the exception. It has got the potential to cause pandemic as well as endemic, and if we believe in the whatever data available from our country, it is contributing almost to the 8 to 10% of all acute respiratory infections in our OPDs or in IPDs. Also responsible for acute LRI. significant mortality and morbidity has been seen with the flu viruses. As we know, there are three viruses, A, B, and C. A, which is there are other hosts than the human, like pigs, other animals, and birds, and has a capacity to call pandemic. What we have already seen, which we have already seen in recently in 2009 novel flu pandemic or swine flu, what is popularly known called as. Type B is transmission is only between human to human, can cause endemic and not pandemic. C is not very commonly seen, so we'll not discuss. Another important point, the virus is so fragile, can mutate very frequently, almost every year. And when the mutation is mild, we call it as antigenic drift. And when the mutation is significant, more than 15%, we call it as antigenic shift. And when there is an antigenic shift, the whole population who was initially protected is now no more having the same protection. And this antigenic shift can cause pandemic, and which we have already seen in the swine flu. If you want to have the vaccine efficacy the best, we should have the vaccine strains. They are compatible with the strains which are circulating. So the vaccine strain, they are same as the strain, then we'll have the best vaccine strategy. Now let us ask few questions to ourselves. What are the strains which are commonly circulating at present in India? There are two from the type A and two from the type B. Type A is H3N2 and H1N1, whereas the type B, there are two lineages called as Victoria and Yamagata. These four strains are commonly circulating, and if you will see the vaccine description, you will have the strain only in our vaccine. How the companies decide which strain to include in the recent vaccine, it's very important. For this, you should know what is GISRS, that is Global Influenza Surveillance and Response System. This is the one which is controlled by WHO, having 142 sub-centers across the globe. And there are some controlling centers, about 5 or 6, with multiple microbiology labs. What they will do, they will collect these samples across the globe and will send it to these centers. The centers will collect the circulating strains during that period from the southern hemisphere and the northern hemisphere, where the world is divided into two hemispheres approximately, to get the best possible strains from these areas. And now these most commonly circulating strains from the southern hemisphere and the northern hemisphere will be given to the microbiology lab, and hence the seed is given to the pharma company to prepare a vaccine. So what this GISRS is doing, the most commonly circulating strains are given to the pharma company to prepare the vaccine. Then you know that the southern hemispheric vaccine is available around April onwards, and the seed is given 6 months prior, that is around September last year, to the company to prepare the vaccine. It takes about 6 months. And the northern hemispheric vaccine, which are usually available this time, that is September, October onwards, the seed is given to the pharmaceutical companies around February. So we know why the southern hemispheric vaccine and northern hemispheric vaccines are available at this time. Which vaccine should be preferred in India? This is a very important question. Though India is placed in the northern hemisphere, you will know most part of the country follows the southern hemispheric pattern. That means the monsoon, post-monsoon, and the usually the season matches with the July onwards. So July to December, except some part in Karnataka onwards, which has little late monsoon season, that is in October, November, and extreme part of the north, where the season is usually January, February onwards. So most part of the India behaves the southern hemispheric. So most of us should prefer southern hemispheric vaccine, excepting few which will prefer the northern hemispheric vaccine. Should we go for the trivalent or quadrivalent? If we'll go with the history, it started with monovalent, then bivalent, in trivalent. With the problem with the trivalent, initially we thought either of the two type B, we can use either of one. But it was noted that there was a mismatch almost to the 50% in these lineages. So either the Yamagata was selected or the Victoria was selected. And we should always remember there is a core circulation of both of them. Therefore, now it is mandatory for all of us to go for a quadrivalent vaccine. Whatever the vaccine by the company are using, always go for a quadrivalent vaccine, which will have H1N1, H3N2 from type A, and 2 lineages with gamma kata from type B. Split virion vaccine versus subunit vaccine. The single line question, do not split your hair on the split virion and subunit vaccine. Both are equally good. The split virion vaccine will have internal as well as external antigen, whereas the subunit vaccine will have only external. So as far as this, just in one line, this split virion vaccine has both the antigens, having good immunogenicity but higher reactogenicity. T cell response is better with split virion, having better immunogenicity in children between age 6 to 47 months. But as far as the vaccine efficacy is concerned, both split virion and subunit vaccine, they are having almost the same vaccine efficacy. So do not go after it, whether it's a split virion or subunit. Go whatever is available in your area. What are the recent ACVIP recommendations regarding doses? Now, this is very important. Uniform dosing of 0.5 ml dose intramuscularly is advocated to all above 6 months of age. From 6 months to 8 years, it is not 9 years, 6 months to 8 years of age, 2 doses are given as a priming when you are giving it for the first time. Then subsequently you have to give only 1. After 9 years, you have to give only 1 dose per year, preferably pre-monsoon or monsoon time. That we'll discuss subsequently. What are the ACVIP recommendations regarding age group of the beneficiaries? When we are giving it for the first time, 2 doses 1 month apart, up to the age of from 6 months to 8 years, and age group, first 5 years we should be given every year. After 5 years, on a specialized high risk group. Who is the age group? Always immunocompromised, chronic lung diseases, chronic heart disease, chronic renal diseases. Immunocompromised patient should be given even after the 5 years of age. Why a universal recommendation is not possible? Disease burden in our country, we do not know which age group should be targeted. Then we are not very sure, because of the limited data available from our country, we are not very sure whether there is going to be a mismatch between the circulating strains and the vaccine strains. It is going to be a huge burden financially, because every year we'll have to give to everybody. So considering all these things, the ACVIP or even the WHO has recommended that you should give it to the high risk, and for a pediatrician, high risk is first 5 years, and after 5 years, those who are having these special situations which we have already discussed. As far as the vaccine efficacy is concerned, see, with the different criteria, the vaccine efficacy will differ. As far as the culture positive, it is around 65%. If it is confirmed by the serology, it is around 63%. In clinical cases, it matches only with 33%. But is it correct? No. For the exact vaccine efficacy, the other points should also be in the consideration. What is the efficacy against the otitis media? What is the efficacy against the number of patients visited to your OPD, even in IPD, and the efficacy against the work days lost. So if you consider all such things, the vaccine efficacy will be very good as against what it is said, 65%. Why has this change in the volume of dose? That you should understand. When it was introduced for the first time, wholesale influenza virus vaccine was available, which was highly immunogenic but highly reactogenic also. Especially in the age group of 6 months to 3 years, the reactogenicity was very high. So they have reduced the dose to 0.25 ml from 0.5 ml, and slightly at the compromise situation, but reactogenicity to be avoided, giving 0.25 ml. Now the split virion and subunit vaccines are available. They have shown excellent immunogenicity without increase in the reactogenicity. Then it is having even the antibody titers are very good, especially in the age group of 6 months to 17 years, very well tolerated. So now ACVIP has strongly recommended that uniform dose of 0.5 ml must be given. For at present, to my knowledge, Influenza tetra and Fluarix tetra, these 2 vaccines have got this uniform dosing permission by DCGI, and I'm sure the Sanofi has already applied. So in next few months, all the vaccines manufacturing, the companies of this influenza virus vaccines will have this uniform dose of 0.5 ml. Now, few questions. A 3-year-old child comes for flu vaccine. He had taken only 1 dose last year. How many doses should be the child should receive? Always remember simple. If he has received only 1 dose, this time you will have to give 2 doses. So this child should be given 2 doses 1 month apart, and from next year you will be giving only 1 dose. Then if the child has received the child who is 4 years old and who has received 2 doses in the first year of life, he has not received anything after that, and now he has come. Again, the rule number 1. If any time, whether in the same season or in the different years, if he has received 2 doses before attending your OPD, you are supposed to give only 1 dose. So this child will receive only 1 dose, and next year also will continue with the 1 dose. After recovering from flu, does the child need flu shot, and when? Yes, because the person must have suffered from one particular strain, still he is prone for other, the circulating strain like type A and type B. So he should be given a flu vaccine as soon as he has clinically recovered. These are the different vaccines which are available, and I'm sure all of us must be knowing about this. So no more discussion on this. If this is, few questions can be taken subsequently. We'll go ahead with the second most important rabies vaccine. Before I start this rabies vaccine, today is a anti-rabies day. Today is an anti-rabies day because today is death anniversary of Louis Pasteur, and our salutes to this person who has given so many vaccines and first anti-rabies vaccine. And he has saved so many deaths in our world. Our salutes to him on this particular day. Rabies, a very, very important disease, very important, a virus, a very important zoonotic virus, and very important to us. And there is no reason why everybody should not know 100% about this disease. The most important thing which you all should remember, this has got the 100% fatality, but 100% disease can be prevented. There are about 60,000 deaths annually in the world, but I'm sure this is highly underreported. And most of the deaths are occurring in the developing countries like Asian and African countries, and India contributes mainly a lot. Another study which says that 40% of the cases of rabies are less than 15 years of age, and we know a pediatric population is at risk because of so many disadvantages of age, cannot protect themselves, many times they do not tell, and multiple injuries, they try to hide, and they are usually the sufferers maximally. These are the different vaccines which we are going to discuss. And all recent, now the nerve tissue vaccine which was introduced first time is no more in the use, and these are all good CCE vaccines available, and these are few names which we are going to discuss subsequently. What everybody must know about the anti-rabies vaccine, all brands are killed vaccines, they are all good, all are safe and highly immunogenic. Either they are 0.5 ml or 1 ml, given intramuscularly or intradermal. For that, every vaccine should have antigenic content more than 2.5 international unit per dose. Once you have reconstituted, you have to use it within 6 hours. What are the common sites? For intramuscular, deltoid and anterolateral aspect of the thigh. For intradermal, suprascapular is the third site which can be used. Never should be given gluteal in the gluteal region. If it is given accidentally, should be considered as invalid dose. It is to be given in class 2 and class 3 bites, which we are going to discuss subsequently. This is rabies is a medical emergency, and there is no contraindication. I think this is the only vaccine where there is no contraindication. And you should always remember the last line. The vaccine induced immunity starts developing from 7 days onwards, and usually it is completed in almost everybody in an immunocompetent person by day 14. And 7 days are very important, which is called as window period, where you want to protect an individual before he himself will protect by developing antibodies after the vaccine has been given. Treatment strategy, always remember 3 important pillars: wound toileting, anti-rabies vaccine, immunoglobulins. Wound toileting is such an important thing that as soon as you get the patient, hold the wound under the tap water for 10 to 15 minutes, clean with any antiseptic iodine or chlorhexidine. Then this will take care of almost 50% of the viral load. Such an important thing should never be missed. Even if the patient has come little late, still wound toileting has an important role to play. Then rabies vaccine we have already seen to generate antibodies against the rabies virus to protect the individual, and immunoglobulin very important role to protect an individual in first 7 to 10 days, which is called as a window period. So all these 3 pillars are equally important. And other supportive management, you can continue like giving a TT vaccine or antipyretics or antibiotics. Then another 3 things which you should always remember: category. Everybody must learn. It is very easy to remember. Type the category 1, where there is leaks on the intact skin, or you have played with that animal, or you have done it, where what treatment is required? Only wound toileting. If you are little worried about your skin, you can do a wound toileting. In category 2, when there are abrasions or there is nibbling without a blood, here no immunoglobulin, but only anti-rabies vaccine. The exception is immunocompromised person. Even a category 2 should be treated as category 3. Category 3, I tell you, all the patients, almost 90% of the patients who are coming to, they come to this category 3 because they will always see at least a drop of blood after a bite, and so it becomes category 3. Here treatment is, if previously not protected, either by pre-exposure or the post-exposure, rabies immunoglobulin as early as possible, start anti-rabies vaccine, the schedule which we are going to discuss, and a wound toileting. All these 3 things are very, very important in category 3. What is post-exposure prophylaxis? Friends, we have already discussed that incubation period of rabies is from few days to few weeks to few months. So we are taking advantage of this, that it is going to give us little more time to act even after an exposure. So what is the post-exposure? We are already going to ISN protocol, 5-dose schedule, intramuscular, day 0, day 3, day 7, day 14, and day 28, which is also recommended by NCDC, that is National Control of Disease, National Center for Disease Control. Whereas recently, few years back, the WHO guidelines, the ACVIP has also recommended, the CDC has also recommended 4-dose schedule. Intramuscular on day 0, day 3, day 7, and 4th dose is going between day 14 and day 28. So instead of 2 doses, they have recommended 4. There are enough evidences to support this system, but the government or NCDC is yet to ratify these WHO guidelines, which are recommended by ACVIP also. Can post-exposure rabies prophylaxis be given intradermally? A big yes. And enough studies to say intradermal doses are as good as intramuscular, if not better than this. And if you go to the NCDC recommendation, it is already in the recommendation, that is updated Thai Red Cross schedule of 8 doses. So 22202 means 2 site injections of intradermal on day 0, day 3, day 7, then no dose on day 14, but another 2 doses on day 28. So 4 doses are given in these 28 days. Thai Red Cross regime, 222011. Instead of giving 2 doses on 28, they have given one on 20th and one on 19th, because they are basically acting like a booster. There is one more recently introduced by WHO, that you can give 2 site 0.1 ml intradermal on day 0, day 3, day 7, which has also come in this WHO position paper 2018. Again, the bottom line says it has to be ratified by government. So I'm sure it will come in NCDC in the next couple of months period. What is pre-exposure? We have studied post-exposure. But can we protect the individual before he is exposed to an bite? Yes. We already were knowing that NCDC also has recommended 3 doses, 0, 7, 28, single dose on day 0, day 7, day 28, intramuscular, 3-dose schedule. Recently, the WHO and ACVIPA has recommended only 2 doses on day 0 and day 7. Similarly, pre-exposure intradermal route can also be given. Similarly, 3 doses, 0.1 ml intradermal single site on day 0, day 7, day 28. WHO says 2 doses are enough, day 0, day 7. What is Zagreb protocol? Usually there are 2 situations. Either the immunoglobulins are not available or patient has come little late, or if you feel that this is a major injury covering the head, neck, face or the palms area, you can double or triple the dose of anti-rabies vaccine because the immunoglobulins are not available. You would like to give more antigenic load so that more and more antibodies will be formed rapidly to protect an individual before the virus enters the neuronal tissue. This is a very important statement. Rabies immunoglobulins, monoclonal types. We should know the passive protection given to an individual before he develops his own active protection. What are the available things? Human rabies immunoglobulins, equine rabies immunoglobulin, and monoclonal antibodies. As we have studied, the human rabies globulin or the equine rabies immunoglobulin, either the source is horse in equine or the human in human rabies immunoglobulin. The dose is 20 international units per kg for human HRIG. Maximum dose allowed is 1500 international units. For equine rabies immunoglobulin, the dose is 40 international units per kg. Maximum is international units per kg. Whereas now, fortunately, monoclonal antibodies, 2 types of monoclonal antibodies are available. One by Serum Institute, another by Zydus. The monoclonal antibody by Serum Institute is a single monoclonal antibody, human monoclonal antibody. The dose given is 3.3 international, and there is no upper limit to this. So you can calculate according to the per kg. Whereas the monoclonal antibody introduced by Zydus is a murine cocktail of 2 monoclonal antibodies, and the dose which is given is 40 international units per kg. Both the monoclonal antibodies, HRIG or ERIG, should be infiltrated locally as much as possible. And another thing which was there in the past, there is no role of giving intramuscular immunoglobulin to any of the patients. So this should be the take-home message for all of us. These are different types of rabies vaccines which are available, and the immunoglobulins are available. This twin rabies from Zydus, Rabies Shield is from Serum Institute, Berry-Rab, I think this is human rabies immunoglobulin, and Equirabies, equine rabies immunoglobulin. Now, there are few questions which are in our mind. If both immunoglobulins and monoclonal antibodies are available, what one should use? I think practically monoclonal antibodies for the reasons non-availability of human rabies immunoglobulin, extremely costly, the risk of anaphylaxis, the risk of transmission of blood-borne diseases, and may not be available when it is required to the most. Whereas monoclonal antibodies, very cost-effective, easily available, can be produced in any amount. There is hardly any risk of anaphylaxis. There is no risk of transmission of any blood-borne diseases. So, if given a choice, one should use monoclonal antibody, whatever is available, whether it is twin rab or Rabies Shield, you should use it. Until today, in post-marketing surveillance, not a single case of any major side effect has monoclonal antibody. Now, few questions in our mind. 50 kg child with class 3 deep bite, 0.5 centimeter length, human rabies immunoglobulin is still remaining in this syringe. What to do? The dose has been calculated as per 20 international units per kg to be infiltrated locally as much as possible. Always keep in mind, before giving this, you should examine the complete body if there are other sites also, because they are likely to be missed. you must infiltrate in all the injuries which are there, and you can a single wound, then you should infiltrate as much as possible locally. But that does not mean that remaining should be given intramuscularly. So that concept of giving intramuscularly has been discarded totally. As per weight criteria, 2 vials of immunoglobulins were purchased, though the requirement of 1.5 vial, instead of throwing away, can we give it? No. The only thing in your practice, there is only one patient. So use the maximum dose which is to be given. The remaining should not be used, neither should be given intramuscular. But in a setup like a medical college setup or primary health center, when there are more than one patient, then you can make allocards and should be used in more and more patients if the dose is still remaining in the vial. So can be used in a setup like medical college where there are more number of patients, but not in your practice where there is only one person. Now a 5 kg infant had a big CLW due to dog bite of 10 centimeter length, but the volume calculated is too small. Then what is to be done? The simple solution to this, you can dilute this calculated amount 2 to 3 times in a normal saline and infiltrate in this wound adequately. If there are multiple wounds, still you can dilute and use this diluted monoclonal antibodies or immunoglobulins in multiple wounds so that to cover every wound. Now suppose the wound is bleeding. What should be done? The rule number 1 says you should not give the sutures to this. You can use the pressure and try to stop the bleeding if it is possible. But if your pressure applied is not enough, then what you should do? First infiltrate the immunoglobulins in the wound and then only give a light sutures just to approximate the wound. Because we want that the immunoglobulin should infiltrate to the wound maximally, will block all the viruses before entering into the nerve tissue, and then we can take care of the wound. So we should always remember not to be in a hurry to give tight sutures. Try always to give to infiltrate the wound first and then give the light sutures. If the immunoglobulin is not available, should we wait for it? No. You should start giving anti-rabies vaccine as early as possible, right from day 1, that is day 0. You can give immunoglobulins up to day 7. After day 7 and you have started anti-rabies vaccine, you should not give immunoglobulin because these immunoglobulins will interfere in the antibody response to the vaccine which you have given. So even if the immunoglobulin is made available on day 5, there is no problem. You have on day 0, day 3, then you give immunoglobulin, infiltrate the immunoglobulin, again continue with the anti-rabies schedule on day 7 and day 14 and 28. So do not wait. I have received pre-exposure prophylaxis, but always get some scratches or bites here and there by your pet dog. Now this is a very tricky situation. Your pet dog will have some scratches because of the nails. But as a recommendation, it says if you have received 3 doses of pre-exposure prophylaxis, that is 0721, or if you have received pre-exposure prophylaxis, post-exposure prophylaxis, for next 3 months, no anti-rabies vaccine is required, no immunoglobulins are required. After 3 months, again, you will have to take 2 doses, 0 and 3. For those who are at risk, like veterinary surgeon, those who are working medical staff in the veterinary colleges, or policemen, or those working in the boys in the Zomato, those who frequently travel from here and there, or army people, or those who are working in the medical labs, the rabies virus, they must take pre-exposure prophylaxis and ensure that their antibody titers are above 0.05 international units, which is a protective value. If it is decreasing, again they have to take 1 booster. But such facilities may not be available. So we have made a thumb rule. Such people should be given 1 booster every 5 years, so that they will maintain these antibody titers above 0.5. After receiving full PAP for dog bite, again was bitten by, I think we have already discussed, he has already received post-exposure prophylaxis. So next 3 months, he is not supposed to take any anti-rabies vaccine or immunoglobulins at all. So this child should only be given wound toileting and nothing else. A big no that somebody has drank milk, because there is no evidence to say that the milk has transmitted any rabies viruses. So, but you should not encourage. If there is any suspected animal, suspected rabid animal, see to it that you are not drinking that milk from that animal. But at present, there are no recommendations. Again, the same. The blood of a rabid dog has not transmitted the disease. So you should not give anti-rabies vaccine or immunoglobulins in this child. But always remember, body fluid like saliva, CSF, urine or tears, they have seen rabies viruses. So if there is an exposure with these fluids, you must take anti-rabies vaccine or immunoglobulin, whatever is required at that time. Suppose there is an exposure to the conjunctiva or mucous membrane, you can use the diluted immunoglobulins and do the flushing of the conjunctiva with the diluted immunoglobulins or monoclonal antibodies, or in the mucous membrane, you can do the rinsing. If patient has developed rash, but as I have said, it's a medical emergency and there is no contraindication, you should continue giving the anti-rabies vaccine under the supervision, because most of the time the rash is because of some component of that vaccine. What you can do, you can change the brand and give the vaccine, but ensure that you have monitored that individual for at least 15-20 minutes in your hospital. If there are no signs or symptoms of any allergic reaction, you can safely send that patient and complete the vaccination. I think interchangeability of brand is recommended in this, because basically we want to protect an individual. Do not be after that, I must get the same brand. Whatever brand is available, see to that you have completed the anti-rabies schedule, vaccine schedule. As I said, there is no contraindication. So pregnancy is also not a contraindication. You must go ahead. For 2-day-old newborn, the same doses. Here you should always remember there is no per kg dose of anti-rabies vaccine, though it is for immunoglobulin. For anti-rabies vaccine, from day 1 to 100 years old person, the dose is same, whether it is 0.5 or 1 ml. This is an important thing. A child has approached 10 months after dog bite. On local examination, scar mark is visible. What you should do? Suppose this is a traceable animal, and if he is alive, there is no need to give anything. But if it's a wild animal, non-traceable animal, even if he has come after 10 years and there is a scar mark, because we have seen that the incubation period could be in few months to few years, this child will be given the same vaccine schedule with immunoglobulin infiltration and all doses of anti-rabies vaccine as soon as possible, because there is still possibility that the virus is still there because the incubation period is very high. So we should continue the same treatment for this child also. Can we use intradermal regimen in your office practice? There are only 2 indications for intramuscular. This intradermal, yes, but the DCGI has given permission to 2 brands to use intradermal regimen. In medical colleges, the studies have already started. But see, in our practice, usually we get 1%. So there is no point in giving intradermal and investing the remaining part. So in our practice, we can go with the intramuscular dosing, and intradermal injection requires a skill. And if you have not developed a skill for giving an intradermal like what we give it in BCG, a disease which has got 100% mortality, you might be taking a risk of not giving exactly intradermal. So if you are confident, if you are trained, usually in a setup like medical colleges or in PSC, where there are multiple patients in the line, you can give intradermal doses to save the vaccine, to save the cost, and the same vaccine can be given to more number of people in a medical line, these medical colleges. We will not discuss this because this Cadila has introduced this 3-dose 037 will be very useful for all of us. But then at present, it is not recommended. DCG has approved to be given after the age of 18, not yet approved before 18, not yet recommended by NCDC. or WHO. So we'll wait for this, but this is just for our information and not. These are the different brands which all of us are very. This last statement before that, is there any indication of intramuscular? There are only two. If there is an aerosol exposure accidentally, because you never know where to give local infiltration, you can give intramuscular dose of immunoglobulin. Or secondly, because of the bat exposure. In the Western world, all the cases of rabies are because of the bat exposure, not because of the dog exposure. So they are very much worried. If somebody has traveled to an bat or somebody in the single room was exposed to the bat, but he is not very sure where it has bitten, then instead of infiltrating, they are still recommending, the CDC is recommending, give intramuscular, whatever is the advantages, we will give it, followed by anti-rabies vaccine. With this recommendation, I stop here. Thank you so much for the opportunity given.
So if you go to slide 359, I can start. Marathi, sir?
Yes, yes. Should I go ahead or somebody else is?
I have to present because I'm at the airport now, so I have to present
should
the
I stop
AEFI.
sharing or I will continue?
No. Continue the slide to AEFI. I'm requesting you to go to slide 359 so that I can continue.
Just a minute.
Do help me, sir. Sorry. Sir, after this, AEFI.
Just a minute.
Thank you so much for cooperating, sir.
Absolutely, it's a pleasure. We'll start with AEFI.
Yeah. Yeah. So when we talk about AEFI, the surveillance, the objective of AEFI surveillance would be to maintain confidence by addressing the parents, the community concerns, and raising awareness about vaccine risks. Furthermore, to detect, correct, and prevent immunization errors wherever they are. Then again, a very important part is to prevent false blame arising from a coincidental adverse event. And therefore, once we identify which vaccine lot, which brand has caused it, we would be more careful in future. And we would be actually getting the confidence of the parents and the community. Next slide, sir. Next, sir. So while defining AEFI, the definition is that AEFI is any untoward medical occurrence that follows immunization and which does not necessarily have a causal relationship with the usage of the vaccine. So AEFI can be due to the vaccine, without the vaccine as well. And the adverse events may be any unfavorable or any unintended sign, abnormal laboratory finding, symptom, or disease. An enlarged liver is an unfavorable sign. A laboratory finding of thrombocytopenia would be a laboratory finding. A symptom like itching and redness could be there. And of course, with certain ones, we can have meningitis, etc. So next slide, sir. So when we say types of AEFI, we have minor, severe, serious, but when you think of cause-specific definition of AEFI, we have vaccine product-related reaction, which is an AEFI that is caused or precipitated by a vaccine due to one or more of inherent properties of the vaccine product. Then we have vaccine quality defect-related reaction, an AEFI that is caused or precipitated by a vaccine that is due to one or more quality defect of the vaccine product, including its administration device. So we'll discuss the examples now. So this also includes administration device problems, which is provided by the manufacturer. Then comes immunization error-related reaction. This is an AEFI that is caused by inappropriate vaccine handling, prescribing, or administration. Next comes the immunization anxiety-related reaction. Next slide, sir. The immunization anxiety-related reaction is due to anxiety. Supposing you have a vasovagal in an adolescent when you've given an HPV and she suddenly drops down. So there is rarely any convulsion, rarely any breath holding. Mostly there would be hyperventilation or vomiting or a sudden fall on the ground. Then you have some coincidental events, an AEFI that is caused by something other than the vaccine product, immunization error or immunization anxiety. So there could be something which is coincidental along with this. Next, sir. So while giving an injection, needle broke as the child was violently moving all the limbs. Now, what type of AEFI is it? This is a question which everybody can relate to. So this is an immunization error related problem. Next slide, sir. While giving an injection to a child who was adequately and firmly restrained now, the needle broke. What type of AEFI is this then? Give it a thought. This is a vaccine quality related error. Next slide, sir. Next, sir. Maculopapular rash developed on day 2 of giving MR vaccine. Is this a vaccine product related AEFI? This is a very tricky question. Now you must know what is the time limit of appearance of AEFIs for each particular vaccine. We now have a very good WHO, a whole booklet saying which time window or time frame is for each vaccine. And we all know that for MR vaccine, fever comes after 7 days, rashes after 2 weeks. So next, sir. So if it is 2 days of vaccine, it is difficult. It is not in the time window frame. Next, sir. So now, what is the report of what to report as AEFI? So you have, as I said, minor AEFI. The child may complain of a little headache or a little sort of shivering. That is not a report to be given. So all serious and severe AEFIs must be reported. These should be disabling, these should be life-threatening, and they do not, if they're severe, they will not lead to long-term problems. But serious AEFI would require hospitalization. So non-hospitalized cases of anaphylaxis that have not required, that are recovered also, you must report them. So high fever, hypotonic, hyporesponsive episodes, these must be reported. So the time frame here is within 30 days, but there is no time limit actually. So they can be reported anytime. Next. What is not to be reported? As I said, minor events like minor swellings or self-limiting reactions, which pose very little danger. These occur within few hours of infection and resolve after a short period of time. Some pain, some swelling, a vasovagal attack, or some irritability at the injection site or malaise. So these are minor reactions which do not require to be reported. Next, sir. Next, sir. Now, the reporting of AEFI, there is a whole channel to report for AEFI. So when you report, they are first brought to the notice of the health system by either the patient directly or the healthcare worker who administered the vaccines or the care provider treating the case or the supervising immunization staff, whoever first comes into this thing. And sometimes it so happens it's the local media who creates a halla about this. Now, there is also a monthly routine reporting of all serious things. So when we say reporting, there are reporting forms, case reporting forms, CRFs. We have case investigation forms, CIF. Other than that also, you can see here the flow of how it goes. First, the Anganwadi or the ANM reports in an FIR. Then it goes to the district level where the CRF is studied within 48 hours and preliminary investigation form is filled within 10 days. It then goes to the director, family welfare and the state immunization officer at the state level. Then again, you have a 70-day period where you form a final case investigation form and then goes to the national level and then to the causality assessment is done at the national level. And the final case investigation form is within 100 days. Other than this also, we have other documents like verbal autopsy of the child or verbal autopsy of the adult. So these forms, the purpose actually is the most basic information should be available for decision making at all levels. This captures only minimal information in CRF, regarding the patient, the event, the vaccine, the diluent, and things of that kind. So CRF should be filled actually by a direct doctor or a medical officer and submitted complete to the district immunization office. The purpose is to collect information, and for any serious thing, the report is AEFI must be actually documented. Next, sir. Next, sir. So there are some important tips, like I said. MR, I said time frame is important. So you must look up the time frames, whether the AEFI can happen within this time frame or what time frame we should advise the patient about. So proper history must, you have similar episodes in the past or not. Like with DPT, if you've had a convulsion previously, it is important to know. AEFI reporting and surveillance is very important. As I've told you, it is to collect information and share for any serious or severe side effects. Sometimes a batch or a brand of vaccine may be at fault, and we must know about that also. And then, of course, the menace of media management in case of AEFI, we should know that vaccine hesitancy is there, media reporting is there. So we have to understand how to manage the media at these particular times. Then preserve the vaccination records, the temperature charts, the vials, and the used syringes. Please do not throw them away within the time frame. IIP members and pediatricians are always part of the AEFI committee, like many of us over here, faculty, maybe chairpersons or maybe members of the AEFI committee. Next, sir. Next, sir. So anaphylaxis, we're talking about anaphylaxis now. Well, anaphylaxis, you all know these anaphylaxis specifically, which is, we'll talk about vaccine-related anaphylaxis. Next slide, sir. Next slide, sir. So let us look at the causes of anaphylaxis in vaccines. So any vaccine antigen or an agent which it is conjugated. One famous is the stabilizer, the gelatin. Then we have antimicrobials in certain vaccines like the streptomycin, neomycin combinations, and preservatives like thiamersol. There are other adjuvants also which may be responsible, and allergy to mediums in which the vaccine is prepared. For example, eggs, chicken. We have the vaccines which are made in these, and those who have egg allergies cannot be treated on these vaccines for fear of anaphylaxis. Next slide, sir. So there is an immediate response. There is a late period of response. When you say there is an immediate response, we have it in less than 30 minutes. However, if we have a late response, there could be a recruitment, eosinophilic recruitment, and then you can have a late response. So exposure to reaction there is biphasic, and it can be between 2 to 12 hours, the first stage, and then it could be 1 to 28 hours. And 5 to 23% in adults, and seen 6% in kids. And remember always, because it is biphasic, the second reaction could be worse. Next, sir. Now, a 15-year-old female who has been given HPV vaccine suddenly fell down unresponsive. Is this anaphylaxis? My fellow colleague asks me, should I give adrenaline? No. So this is not anaphylaxis. This is a minor sort of vasovagal attack, and you just need to reassure, make the child lie with the legs raised, and this is without any brady, this is without any respiratory difficulty, without any urticaria. So first and foremost, next slide please, we must know that we have to differentiate anaphylaxis and its mimics as per the WHO chart. So this is one flow chart which is available for every ANM, where an early onset within a few minutes to 6 hours and rapid progression with one sign from two systems, either respiratory, cardiovascular, dermatological, or other symptoms. There should be two signs from two symptoms from any two systems like respiratory, cardiovascular, and dermatological. So then we say it is anaphylaxis. Next. and the emergency tray. Now, this is a very important thing that we should all have. I've recently had somebody who asked, can I give noradrenaline in place of adrenaline? And I said, no, you cannot give noradrenaline in place of adrenaline. So an adrenaline, which is of a very quick expiry, you need to check expiry dates all the time. Then you have an IV access and angiocats, and you have normal saline for bolus dose or ringer. And you have an oxygen supply, which you have checked that it is available, and it's not just finished at the last minute. We are not screaming, sister, isme to kuch hai hi nahi. Then we have the resuscitation trolley, where we have the laryngoscope, the amber bag, mask, and the endotracheal tubes of various sizes. And then you can have oral prednisolone or hydrocortisone injection, oral antihistaminics, inotropes, if you can keep them in the OPD level, and suction apparatus and tubes. Next, sir. So this kit is probably available at all outreach vaccination sites also. And there are the ANMs also have been trained to use this kit as a vaccinator. So once the child is made to lie down, as I said, with the legs elevated, adrenaline in the strength of 1:1000 is used. If the weight is known, fine. If the weight is known, then we give 0.01 ml kg per dose. Per kg per dose, maximum to 0.5 ml by IM route. Note here again, it is in bold. We use for anaphylaxis adrenaline by the IM route on the anterolateral aspect of the thigh of the child, and can be repeated after 5 minutes if required. The rest is all the same. ABCDs have to be maintained: airway cleared, suctioning, circulation, and of course, if required, the child seems to be in shock, we need to give boluses of 20 ml per kg normal saline. And oral antihistaminics here, the IV antihistaminic is not a first line treatment. So oral prednisolone or IV hydrocortisone can also be given. Next, sir. So this is a very useful chart, which all of you can put up in your OPDs and use. This is an instant chart where you can just take a tuberculin syringe and load as per the ml over year, 2 ml, 4 ml, 8 ml, 12 ml, and 20 ml. So insulin syringe, equivalent doses in ml and units. So next, sir. Thank you so much for patient listening. Thank you, Sanjay Marathi, sir.
Pleasure. My pleasure.
Thank you, sir. Thank you. Yes, sir. Thank you. Dr. Sagar Kulkarni is there, who is supposed to moderate. If he is not there, I will ask some questions, sir. The present situation, flu vaccine, we have two brands, Southern Hemisphere and Northern Hemisphere. Both are available.
Yeah.
The patient has come at this moment for the vaccination. He did not come in the month of April, May. So which one should we give, sir?
There is a thumb
Because
rule in
both are
our country.
available.
Yeah, as a thumb rule in our country, because India being a huge country, you cannot think of giving a single type like the Southern or Northern. We have made it very simple. Whatever is the latest vaccine strain available should be used. So at present, suppose both Northern Hemisphere and Southern Hemisphere are available, I will prefer a Northern Hemisphere vaccine, because we should always remember the Southern Hemispheric vaccine is now almost a year old. So my child will be maximally benefited if I use the Northern Hemispheric vaccine from say 1st of September onwards.
Thank you, sir. Thank you. It is very clear that whatever the vaccine recently released should be used for the vaccine.
Yeah.
So suppose the child is having some egg allergy, can we give this vaccine, sir?
A big yes. Now CDC has made it very clear that all the patients with even the severe egg allergy can be given flu vaccine, with few important things, that most of them, those who are tolerating egg like pain in abdomen or something, can be given in your OPD. Suppose there is a severe allergic reaction to the egg, then this patient should be given a vaccine under the facilities where you can monitor the child for half an hour. In case of an anaphylaxis, you should be able to manage it. And all patients, because considering the mortality and morbidity, they say egg allergy can still be managed in a hospital. So it's a precaution. It is not a contraindication.
Sir, one more question, sir.
Yeah.
Can we advise flu vaccine to the person who suffered from flu recently?
Yes, I think we have already discussed it. Because there are 4 strains which are circulating and the vaccine also includes 4 strains. He must have suffered by 1 strain out of 4. So as soon as he has recovered from his illness, you can give a flu vaccine to him.
How long should we wait, sir?
As soon as he has recovered clinically, there is no time frame in between.
So for pregnant mother, at what term you will advise this flu vaccine, sir? Because pregnancy is one of the high risk.
Actually, flu vaccine can be given during any trimester of the pregnancy, but preferably should be given in the 2nd or the 3rd trimester, because 1st trimester we avoid because of the organogenesis. So
Okay.
for a safety purpose, you can give it in the 2nd or 3rd.
Okay.
And preferably, I think if we give in the 2nd or 3rd trimester, it will be beneficial for the baby also. Because
Yeah,
there
to
was
some
some
extent, yeah.
that there will be protection against
Some
for a
protection.
baby less than 3 months.
Yeah, and unfortunately, we have no vaccine in for 6 months.
So one more thing, sir. If there is an outbreak situation, it can be given in the 1st trimester for the pregnant mother. So
Yeah.
there is no
You can give.
contraindication.
No, it's not contraindicated at all. Preference is given to the 2nd or the 3rd trimester if given this, but you can give it anytime.
One question, sir, somebody has raised. If the child has taken 5 doses of anti-rabies vaccine, if he comes after 1 month, can we give monoclonal antibody?
Absolutely no. He has
After
already
7
received.
days of the first dose only.
He has received post-exposure prophylaxis on his lifetime. He should not be given monoclonal or immunoglobulins. He requires only 2 doses after 3 months, 0 and 3.
There is no use of giving it because he has already had the
He
antibody.
has already been protected. So you are giving boosters.
I was asked a very peculiar question few days back that a person has received immunoglobulin in past and there was a dog bite again. Can the person be given immunoglobulin? So
the point is,
tricky question.
Rabies, the rabies immunoglobulins are never given in isolation. So this is a very stretching your imagination too far. That somebody who cannot afford an anti-rabies vaccine was given immunoglobulin without any reason. So that is only Ambanis can afford such things.
There was one particular case that a person had taken immunoglobulin. He had taken the first dose.
Yeah.
But then the patient did not turn up for the 2nd or the 3rd doses. So he had not completed the standard protocol of the vaccine. So in such a situation where he has not completed the standard protocol of vaccine, then might be for benefit of doubt, he can be given immunoglobulin. Let us say after 1 or 2 years, if he has had a bite because he never completed the vaccine course.
Sagar, recently, if you read the CDC guidelines, they have included one thing. Even if the person has received only 2 doses, has not completed his post-exposure prophylaxis in the past, still it is considered as pre-exposure prophylaxis and he requires only 2 doses.
So as I said, only single dose.
This is a very, very extremely rare situation.
Any more questions, Radhanath sir?
Sir, one slide is there about this new vaccine, 3-dose vaccine. Can you elaborate it, sir? Can we give that one?
Which one?
PH rabies.
3 doses, new vaccine is known.
That new vaccine which we are not discussing in this platform because it is yet at present recommended only above the 18.
Rabies vaccine is a new vaccine.
It's a new vaccine introduced by Zydus and it is given in the doses of 0, 3 and 7. Some limitations which I have gone through the literature, they have studied this only in the immunocompetent subjects. So there are no studies in immunocompromised individuals. There are no studies also when there is a history of dog bite or something. So there are few limitations and they are, I think, continuing with the few more studies to come out with the better recommendation. So yet to be recommended by NCDC, though it is recommended by DCJ.
Okay, sir. I think there are no more questions. We can go for the next.
Thank you very much, and thank you, Piali madam. a great, I think, a level of commitment from your side that you are
Yeah.
sitting on airport and still you have taken the lecture. I can say you are a
No.
true IIT soldier. That is what I can say.
Thank you, Dr. Sagar, and thank you. A big thank you to Surendranath sir for allowing me. And another big thank you to Dr. Marathe for running
It's a-
my slides.
It's a
Thank
pleasure,
you so much
man.
to all three
Always
of
a
you.
pleasure. Yeah, always a pleasure.
I'm going actually for the West Zone one, and they sent me the tickets, and this is what happened. So I'm so sorry for creating a little bit of diversion here.
Are my slides visible, Marathe sir?
Yeah.
Yeah, yeah.
Okay, so we are going to discuss about HPV vaccine. The original HPV vaccine which we had was the Cervarix vaccine. It was a bivalent vaccine containing 16 and 18 serotypes. And let me tell you, it was the best bivax. What I mean by that, it was a very high value, high impact vaccine because it contained only two serotypes, but it was giving coverage against those serotypes which were responsible for 70 to 80% of cervical cancer. So even though it had only two serotypes, it was a very useful vaccine. And later on, other vaccines like Gardasil 4 came, then Gardasil 9 came, and then Cervavac came. And then the question came that which vaccine should actually be preferred. It all depends on what is the epidemiology of your region, how much is the episodes of anogenital warts which are occurring in your area, what is the incidence of other cancers, because we know that HPV vaccine is now very, very useful for other types of cancers also. So other than cervical cancer, it is going to protect against vulvar cancer, vaginal cancer, anal cancer, head and neck cancers, respiratory papillomatosis, penile cancers, and so on and so on. So you have to understand your own epidemiology of your own region, and then only you can decide that which vaccine is best for you. But let me tell you, the primary target population is 9 to 14 years, and the primary aim is prevention of cervical cancer against the two serotypes 16 and 18 only. That is the primary target. Recently, we had this Gardasil 9. It has extra number of serotypes, and we have this Cervavac from Serum Institute of India, which is also a quadrivalent vaccine. So if you ask me which is the best among this, then definitely the Gardasil 9 is the best amongst all because it is giving coverage against 9 valent. But as I've said earlier in my side, if you tell me, ask me which was the best vaccine, which was the high value, high impact vaccine, it was actually the bivalent vaccine which we had in the past. So, what is the schedule of this vaccine? To simplify, I have put this chart. From the age group of 9 to 14 years, we have to give 2 doses, and above the age of 15 and above, there are 3 doses. So that is in simple terms. Then you have to understand what is the license. If you see the Cervavac is licensed from 9 to 26 years for both boys as well as girls. Gardasil 9 for boys, it is licensed only in the age group 9 to 14 years. The licensing was for 3 doses, but recently ACVIP has brought that in boys also Gardasil 9 can be given in 2 doses based on the bridging study. Sadly, as I've said, bivalent Cervarix vaccine is not available at present. So there was this thought by SAGE committee that why not to give a single dose of HPV vaccine? And the same thought now comes in the mind of the office practitioner that can I use a single dose of HPV vaccine? So SAGE has said that there is now enough data that the seroconversion is occurring with single dose also. And there are many efficacy studies also, like the Kenshi Kenya study, the Costa Rica study, the IFC India study, the Doris Tanzania study. We said that the seroconversion occurs with single dose also, and single dose also is giving efficacy for a long period. So the SAGE thinks that to improve the coverage, we know the target. We have to complete 90% of vaccination to all girls between 9 to 14 years by 2030. So if we start giving single dose, that will be programmatically convenient. So SAGE has said that country might choose from a single dose or double dose based on their own programs to see that this target is complete. But let me tell you, friends, that the single dose at present will be off-label use. So even the government, if it uses a single dose, it will be off-label. For private practitioners, we cannot use a single dose at present. There are some drawbacks. That the GMT titers, if you see by single dose versus 2 or 3 doses, the GMT titers are good with 2 or 3 doses as compared to single dose. Number one, a single dose has not been studied in males. A single dose has not been studied in immunosuppressed population. A single dose has not been studied in older women also. But yes, it is a very good update which we have got. Now let us see some cases. So there is this a 15 years old girl who has come to you not for vaccination but for not gaining weight and general checkup. So will you use the opportunity to explain that child and the parents about HPV vaccine? Now mother has not come to you, but you started explaining to the mother about HPV vaccine. Then the mother tells you no, she will take the vaccine after her marriage. Now what to do and how to explain it to them. You have to explain it that this vaccine, when given in the age of 9 to 14 years, is going to give you very good results because the immune response is better in this particular age group. The immune response is so best that even 2 doses will suffice. There will be no need for using 3 doses. And this is a prophylactic vaccine. It has to be administered before exposure. There is no point in giving the vaccines once exposure or the disease has already occurred. You have to explain these things to the parent. Number four, you have to tell them that high coverage in girls is going to give protection to boys also and even to other girls also. And it can be amalgamated with the existing TDAP visits or even with the existing school health visits also. There is another case. A 35 years old sexually active woman comes for HPV vaccine. What is your advice? I have already told you that the primary target population is girls between 9 to 14 years. And the primary aim which we had in our mind was protection against cervical cancer, mainly by the 2 serotypes, 16 and 18. All others are considered as a secondary target population. Now, what does WHO think? WHO thinks that you can vaccinate the secondary target population, but seeing to it that your resources, your funds are in excess so that you don't divert the funds from vaccinating the primary target population or from cervical cancer screening programs. So if you have that resources, then you can choose the secondary target population, which are girls greater than 15 years, older women, men, older men, and MSM, what we call as the males having sex with males. So that becomes a secondary target population. But this, what I'm talking about is a public health perspective. Now what we are talking about is an office practice. What is said in office practice, you have to give vaccine to all those who demand it. So yes, in this woman also, you have to give the vaccine. What are the points which are going in favor of that? Remember that the woman might not have been exposed to HPV vaccine. You don't know whether she was exposed or not. So yes, you can give the vaccine. Number 2 point, she might have been exposed to a single serotype. So even the vaccines which is multivalent will give protection against the other serotypes also. Number 3, we know that natural infection gives suboptimal immunity. So vaccination is the best way out. The vaccines are not therapeutic vaccines. They are not going to heal the lesions which are already there. But yes, it might lead to some neutralization of virus, which is shared into the cervical vaginal mucus from the prevalent infection. And therefore, yes, in these 35 years, sexually active women, you should give a vaccine. But remember the point that cervical cancer screening program should be strengthened. They are very, very important. Another thing, there is this 12 years old niece who has received the 2 doses of HPV. But what happened that the 2 doses were given only 2 months apart. But she has taken the 2 doses. Now, is her HPV vaccine series complete? No. If you have chosen the 2-dose series, the gap between the 2 doses should be minimum 5 months. And if the gap is less than 5 months, then you will have to repeat the vaccine. This will not be considered as a valid dose. Also, when you have chosen a 3-dose vaccine series, the gap between dose 2 and dose number 3 should be minimum 12 weeks. So these 2 principles you have to follow every time. Another case, there is a 12 years old girl who comes after 1.5 years for the second dose. Should we restart the schedule? No, there is no need to restart the schedule. You have to just give the second dose and the series will be considered as complete. Now, many times what happens, the girl, let us say the girl is of 13 years and 10 months. So we are in a dilemma that the second dose is going beyond 14 years or something like that. Then what to do? So if any girl who was primed with a single dose before the age of 15 years, then she has to be given 2-dose schedule only, whatever may be the timing of the second dose for this child. There was a girl who said, sir, do I really need to worry about HPV? Because Me and my boyfriend always uses a condom. Now let me tell you. So there is a myth in not only the population but in doctors also that HPV is transmitted only by penetrative sex. No, HPV is transmitted by different other uh, uh, modalities also. HPV can be transmitted by oral genital contact, genital contact, manual genital contact. It can be transferred by fomites also. Many times because of using some unused or unautoclaved forceps, biopsy forceps, and speculums also, it has been that HPV can be transferred. So condom is not the most protective way out for prevention against HPV. What is more important is vaccination. Now there is a case that if by mistake a dose was administered subcutaneously, will it be a valid dose? No, it will not be a valid dose. Like hepatitis B, rabies, HPV also cannot be given subcutaneously. You have to give it intramuscularly only. Now, another case, inadvertently, a pregnant lady was administered the vaccine, or after giving vaccine, might be the lady had understood that she had conceived. What is to be done? So, giving a HPV vaccine is not an indication for termination of pregnancy. You continue the pregnancy, but don't give the second dose during pregnancy. You can offer her the remaining part of the series after the delivery in the postpartum period. Another case, there is a 12 years old girl with HIV, that means an immunosuppressed child. Now, in an immunosuppressed child, how many doses we have to give? 2 or 3 doses. Remember, in every immunosuppressed population, you cannot give 2 doses in any age group. The series will be a 3-dose series only. Now, initially, what happened that we had given bivalent cervarix vaccine to many girls because that vaccine was available at that time. But now Gardasil 9 is available. Now we know that Gardasil 9 is one of the best vaccines. So are we supposed to revaccinate all those whom we had given the complete series of bivalent or let us say even the quadrivalent vaccine? The answer is no. There is no such recommendation that you have to repeat the complete series with HPV-9, but there are two situations here. One situation is that a child had received only a single dose of bivalent or quadrivalent, but that vaccine was not available for completion of series. Then the question is, can I interchange the brand? Yes, definitely. So you can give a nonavalent vaccine to this child and complete the series. So that is as far as interchange of brand is concerned and completing the series is concerned. But let us say a woman or a girl child comes to you with the aim of getting a nonavalent vaccine for protection against the added serotypes, then you will have to complete the age appropriate series for protection against that added serotype and not to give just one dose. So that is the actual rule. Now we are thinking, as we know, the SAGE committee has said that even a single dose might work, but as I've said, that is a off-label recommendation. So if someone has come to you with the interest of getting a protection against the added serotypes, you will have to complete the age appropriate series. That is the legal answer. So there was this parent who brought a 13-year-old boy. Will you vaccinate him and which vaccine? Yes, definitely. We have already said that HPV virus causes so many things apart from cervical cancer. It causes genital warts, it causes anal cancer, oropharyngeal cancer, penile cancer, respiratory papillomatis. It is useful in boys also. So you can offer a vaccine to a boy also. Initially, there were no vaccines which were licensed in India, but now the Sarvavac from Serum Institute of India is licensed in boys also, and the Gardasil 9 also is now licensed from the age group 9 to 14 in boys also. So you can offer a vaccine to boys also. It is a gender neutral vaccine. So that is all about HPV. And now going to a short talk on newer vaccines and COVID vaccines. Let us see some newer vaccines. The first one is a Shingrix vaccine. So what is a Shingrix vaccine? It is a genetically engineered protein glycoprotein aggregated with the ASO1B. So the adjuvant, the ASO1 is the liquid form, and the glycoprotein is in the powder form. You have to mix it. It is 0.5 ml given intramuscularly, 2 doses, 0 and 2 to 6 months. Remember, this is not a live vaccine. The Zostavax, which we used to have earlier, was a live vaccine, and there were many issues because most of the elderly have some or the other immunosuppression in them, and so you had to do all the screening of those elderly. But now Shingrix is not a live vaccine, so you can give this vaccine to anyone without even worrying about the immunosuppression part. This vaccine is used above the age of 50 years, and it is given irrespective of prior receipt of varicella vaccine or zoster vaccine, or even if there is a history of chickenpox, history of herpes zoster, it does not matter. You just can give the vaccine without any screening. It is estimated that the immune response will last for more than 15 years. The vaccine efficacy is also very good. The Zostavax vaccine efficacy was not good. So when this vaccine is given above the age of 50 years, the overall efficacy is 97.2%. And even in elderly above 70 years, the vaccine efficacy is 90%. So overall, it is a very good vaccine, but of course, it is a little bit costly, also in the range of 10,000. This is a single vaccine. Mosquito vaccine. This vaccine launched with much fanfare after so much of studies by GSK. It is RTS-SAS1, which is based on the circumsporocyte protein. It is against the pre-erythrocytic stage to prevent the liver stage infection, but it is for protection against falciparum malaria only, and it is not for Vivax malaria. It has to be given in 4 doses intramuscularly, 0.5 ml, 3 doses between 5 to 9 months, and a 4 dose between 18 months to 4 years. So it has already been given to millions of children in sub-Saharan Africa and other regions with moderate to high Plasmodium falciparum malaria transmission. Now, the efficacy is only modest 40%. The issue is whether this vaccine will be useful in India. But in India, now after so many efforts, now the annual parasite index has remained below 1 year. Most of the India is now behaving like a low or at the most to moderate transmission. There are very few patches of high transmission now in India. So more studies are now required whether this vaccine is actually required for whole of the country. There is another drawback that vaccine is not for older children, and this vaccine is not for adults also. But remember that older children and adults are also a part of the transmission. Coming to the dengue vaccine. Now we know that dengue vaccine, which was there earlier, the problem was about the antibody enhanced disease AED, and because of that, the vaccine never came into market. But now this new vaccine, Qdenga, from Takeda company, it is a live attenuated recombinant tetravalent dengue vaccine, and it is a very good vaccine because it does not need pre-vaccination screening. So you can give this vaccine to those who are seropositive also, and you can give it to seronegative also, because from whatever studies they have done in the 4.5 years, there was no evidence of disease enhancement there. So that was a major advantage with this vaccine. One more advantage that it is only a 2-dose vaccine. It can be given 3 months apart. So that is also a good part. Efficacy was 61.2% against virologically confirmed dengue and 84.1% against hospitalized virologically confirmed dengue. So this vaccine was approved in Indonesia in the age group 6 to 14 years, and in European countries, the approval was above age of 4 years also. So yes, this vaccine is one of the promising vaccines which is going to be there, and yes, India needs a very good dengue vaccine, but yes, more studies are required, and let us see what happens. This new vaccine against respiratory syncytial virus, AREXVY, let me be honest, I don't know how to pronounce it, is from GSK. It is for prevention of LRTD, that is lower respiratory tract disease by respiratory syncytial virus. It is used in elderly greater than 60 years, in specifically those with comorbidities. It is a pre-fusion F3 protein-based recombinant vaccine, single dose only, 0.5 ml, and it is also a lyophilized vaccine containing these new adjuvants AS01. Now, trials have shown that there is a reduced risk of RSV, lower respiratory tract disease by 82 to 6%, and reduced risk of severe LRTD by 94.1%. There is one more vaccine, ABRYSVO vaccine, again very difficult to pronounce. Now, as we are giving a Tdap vaccine to a pregnant woman for protection against neonatal pertussis in similar form, this vaccine is also given to the pregnant woman, preferably between 30 to 36 weeks, with the aim of reducing lower respiratory tract disease in the infant, in particularly the less than 6 month age group. So this vaccine is also a pre-fusion F3 protein-based vaccine, 0.5 ml, single dose only, given to pregnant women between the ages of 32 to 36 weeks gestation, and found to be quite useful. As you can see, that the efficacy against severe LRTD was 81.8% in less than 90 days age group, and 69.4% in less than 180 age group. Some side effect in the form of premature birth and jaundice were noted, and they have to be watched for, and more studies are needed, specifically in India also. Few words about COVID vaccines. We have all taken it, used it, though it was never available in private practice, but of course in government setup it was there. And I'm not going to go into details of all the vaccines, but just as a passing reference. So there are many vaccines like inactivated wholesale vaccines, live attenuated vaccines, vector-borne vaccines like our Covishield, which was a chimpanzee adenovirus vector vaccine, subunit vaccines like nanoparticle-based Covax vaccine, the Corbevax vaccine, nucleic acid vaccines like Moderna, Pfizer, and our country's Gemcoac 19 and Gemcoac OM and Zycodi. These were available with us during the COVID times. We have already seen Covishield, Covaxin, Sputnik 5, Zycodi, Corbevax, Covax, Gemcoac 19, and the newest one was the Incovax. But this Corbevax, we know that it was used in children about 12 years. Covax was also used in children. So when actually the emergency authorization was received, government started giving this vaccine to children, specifically through the COVID Act. Incovac is not for children; it is for approved at present above 18 years only. But the most useful part is it is intranasal vaccine. 4 drops in one nose and 4 drops in another nose. So there is the ease of giving. It is a chimpanzee adenovirus vector recombinant vaccine. What is the newest part in this is Gemcovac OM for Omicron. Now we know that the most of the vaccines were against the original Wuhan strain. Then came the Delta strain and other strains and Omicron strain. And sadly, though we used to say that, but the original vaccines with the original strain, they were not that effective against Omicron. And so the thought had come into the minds of all vaccine companies that they have to bring a vaccine either for Omicron or they have to make a vaccine like bivalent vaccine or multivalent vaccine with Omicron and the recent strains which are circulating, similar on the lines of flu vaccine. The same should happen with COVID vaccine. So this vaccine is an mRNA vaccine, made in India vaccine, and one of the advantages is that it is stable at 2 to 8 degrees temperature. There is no need for this -degree temperature and so on. But it is given intradermally, and there is a device called Tropis which is needed for giving this. As I have said, the thought is now in our mind that we want a multivalent vaccine containing different strains, and even if the strain goes on changing and mutating, we want all those strains to be incorporated in the vaccine. That is the part which is going on our mind. Efficacy, we know that any vaccine with more than 50% efficacy was acceptable as per the WHO criteria. But the vaccine, most of the vaccines are effective against severe disease and death. No correlate of protection is yet established. How much exactly the T cell immunity playing role? Still we don't know. So we don't know exactly what is the best time of giving boosters and after what duration the boosters should be given. At present, only those who are traveling to Western countries and those with visa regulations, only they are taking the vaccines. But at present, the vaccine is not available in India, and at present, no one in general population is not taking the vaccine. But tell that Covaxin had received an emergency use authorization above the age 6. Corbevax had received it above the age of 5 years. Covax in the age group of 11 to 17 years, and Zycodi above the age of 12 years. The question remains: is COVID vaccine needed now? So if a child comes to you now, will you offer a COVID vaccine? Let us discuss that out loud when we do the panel discussion, and we'll get to know about the different opinions of our experts. So these are some of the photographs of COVID vaccines. The lower one is the Incovac, the intranasal vaccine. Thank you. Thank you very much for the opportunity. Thank you.
Thank you, sir. It was a wonderful talk. Now we will come to the vaccines in special situation, and that Abhay Shah will be taking. Sir, can you share?
Yeah, I'm sharing. Full screen. Oh,
Yes, sir.
okay. No, but it has gone to the first slide.
Then you have to press and go back to the other. You have to press it continuously.
Yeah. No, I'm doing it. I'm not able to do the slides, so somehow. Okay, no. Slideshow is not every time it happens to me like this.
It's
Do
okay,
you
sir.
want me to share it from my side?
1 minute. Last let it. Last time भी ऐसा ही हुआ था. Mhm. Anyway, please share from your side because it comes to first slide only every time.
Sir, you have to click on the slideshow button. You have
But
not clicked it.
when I'm doing it on slideshow, it
No,
goes.
no, slideshow from
Okay.
the present.
Yeah, it has done now.
From beginning.
Okay. Yeah.
Not from the beginning.
No, from the present slide. You have to click from the present slide,
1 minute.
not
Yeah,
from the
okay.
beginning. From
Yes,
the current
yes.
slide.
Correct, sir. Yes, I got it. Yeah.
Otherwise, you can go to the down. There is one.
Yeah, but that is not visible. Somehow, since last 2 times it happens like this.
Click from the current slide.
Current slide, sir.
Yeah, thank you.
Yes, sir.
So we move on the last topic of the today's session and of all. I think it is the last session of all the 3 days sessions. That is vaccination in the special situation. Now it is very important that whenever we give a vaccine, we follow certain specific immunity schedule for that particular age and for that particular population. But there are certain situations where we need to change the immunity schedule, either in terms of the dose or in terms of the number of doses or the quantity of doses. So what constitutes special situation as far as the vaccination is concerned? So a situation in which the administration of the vaccine may result in a suboptimal efficacy or there is increased chance of adverse effect following that immunization. So it is very important that when we do a immunization to any child, suppose an immunocompromised child, you know that the efficacy is going to be suboptimal. The immune response is not going to be that robust. At the same time, they are more prone to AEFI, especially when you're using a live vaccine. Sometimes the attenuated organism may turn out to be virulent for that particular index immunocompromised child. So this constitutes a very special situation where the vaccine efficacy is suboptimal and the chances of the adverse reaction following vaccination are very high. In such circumstances, the schedule and the procedure should have to be modified either to maintain the maximum efficacy or to prevent the adverse effect. So the aim is to have a maximum efficacy as far as possible and to have the least of the side effect as far as possible. So if your child is on a steroid therapy, a child who has got an antibiotic therapy, or the child has got mild URTI or mild gastroenteritis, they are not the special situation. And remember that the special situation is different. Now, when we discuss about the special situation, the first and important thing comes in our mind is an immunocompromised child. And when we are immunizing a child who is immunocompromised, we have to follow certain general principles. So what are they? So in general, all inactive vaccines can be given, but remember that the immunogenicity and the efficacy of this inactive vaccine may be suboptimal. So they may require repeat doses, they may require booster dose, and sometimes you have to document whether the child is seroconverted or not after the vaccination is completely over. Similarly, in severe immunodeficiency, all the live vaccines are contraindicated because they are going to be very risky. The attenuated organism may turn out to be a virulent in a severe immunocompromised child. So in all severe immunodeficiency, all live vaccines are contraindicated. However, if there is a mild to moderate immunity, then live vaccine may be given provided the benefit outweighs the risk involved for that particular live vaccine. So in a severe immunity, live vaccines are contraindicated. In a mild to moderate immunodeficiency, you have to take a call from individual to individual. Remember that household contacts are also very important. So household contacts of an immunocompromised children should also not receive the vaccine which can be transmitted easily to the child. Suppose the oral polio vaccine or a rotavirus vaccine, you have to be very, very careful. You should not give to a household contact because the household contact can also pass the disease to a immunocompromised child. Similarly, a cocooning effect strategy should also be utilized for protecting vulnerable individuals. Sometimes the higher doses are required, more number of doses are required, and even boosters are indicated in some of the cases. The classical example is hepatitis B and hepatitis A. In a chronic liver disease, sometimes immunocompromised hemodialysis, we know that double dose are required, and sometimes usually we don't go booster, but these are the cases where even booster doses are also indicated. And remember that antibody titers should be checked post-vaccination on regular basis, and once the vaccination, when the antibody titer falls to a non-protective level, you have to again give the repeat dose of that particular vaccine. And the immunosuppression can be judged by using the CD4 count. Here you can have a CD4 percentage as well as absolute CD4 count, which will help us decide whether the child is suffering from a severe immunodeficiency or the child has a mild or the moderate immunosuppression. Now, when the CD4 count is more than 25%, we said that there is a no immunosuppression and we can give all the live vaccine, even the killed vaccine can. So we can give all the killed vaccine and even the live vaccine can also be given. If the CD4 count is between 15 to 24%, it's a moderate immunosuppression, and here you have to weigh the risk and the benefit which is obtained. If the risk benefit ratio is in favor of the patient, of the child, then you can give the vaccine. If the CD4 count is less than 15%, is a severe immunodeficiency, and in case live vaccine is contraindicated, here the risk of the vaccine-induced disease is more compared to the disease itself. And however, here kill vaccine can be given, but efficacy is going to be low, and in that case, you have to document the seroconversion. Beyond the age of 5 years, it is not the percentage, but you have to go for the absolute CD4 count. If the absolute CD4 count is less than 200, it indicates there is a severe immunosuppression, and again here you cannot give any live vaccine. Now, the commonest special situation in your day-to-day practice is the steroid therapy. We use steroid very commonly in a patient like nephrotic syndrome, or when we use as an immunomodulator for number of conditions. So remember that when the steroid dose is given for more than 2 weeks, in a dose which is more than 2 milligram per kg per day till 10 kg of the weight, or if the child is receiving more than 20 mg per day, then it becomes a contraindication for the live vaccine. In that case, you have to first stop the steroid for 1 month, and then you can start the live vaccine 1 month after the stopping the steroid. So that is 1 month is very important. You have to first stop the steroid and give the live vaccine 1 month after stopping the steroid. However, a kill vaccine can be given, but the immunity achieved may be lower. But if the steroids were given for a shorter duration, means less than 2 weeks, even in a high dose, or in a dose which is less than 2 mg per kg day, or if the child is on a steroid which is alternate therapy, or if the child is on a low maintenance dose therapy, then all vaccine, including live vaccines, can be given. So alternate therapy, low dose therapy, aerosol therapy, topical steroid therapy, all do not form the severe form of the immunosuppression, and they can be given both live vaccine as well as the kill vaccine as well. Now, another important thing that patient may have got the functional asplenia, there may be hyposplenia, or sometimes the patient might have undergone the splenectomy. So what is the role of spleen as far as our vaccination and immunization is concerned? Remember that spleen is very important organ for the opsonization of the various organisms. And for the option of phagocytosis, we need to have a very efficient spleen which is working efficiently, and or if the spleen is not working properly or the child has undergone splenectomy, they are more prone to various infections with the capsular organism like our pneumococcal or meningococcal disease, or sometimes even the Hib and the typhoid vaccine. So these children are more prone to fulminant sepsis because of the organism like pneumococcus or the meningococcus. And therefore, any child who has got the asplenia, hyposplenia, or splenectomy, in that case, the vaccine against the capsular organism is a priority. Here cost does not matter. You have to buy, borrow, or steal. But these children must get your pneumococcal conjugate vaccine, meningococcal conjugate vaccine, Hib vaccine, typhoid vaccine, and even influenza vaccine should also be given. Remember that this vaccination should be given at least 2 weeks prior to the splenectomy. So you have to plan your immunity schedule in such a way that all the vaccine is updated 2 weeks before the splenectomy is planned. Sometimes if there is an emergency splenectomy is carried out, in that case, once the child recovers in a post-splenectomy period, you have to complete all the vaccine because the chances of fulminant sepsis is very, very high in such cases. Now, sometimes the children receive various antibody containing products or the various blood products. Now here, there are various antibody or immunoglobulins present in the blood, and they will interfere with the humoral immune response initiated by the parental live vaccine, like measles containing vaccine or MMR vaccine or the varicella vaccine. So remember that here in those children who have received antibody containing product, they can be given inactivated vaccine safely at any time. But remember that a live vaccine, that is parental, not the oral or the nasal, that is MMR vaccine, varicella vaccine, live influenza vaccine, they should be given at least reasonably from 3 months to 11 months, depending upon the dose of the blood product which is used, dose of the immunoglobulin which is used. So it is very important that you have to have a gap of minimum of 3 months, or sometimes this period may be extended to even 11 months, depending on the dose of the immunoglobulin. So antibody containing products should also be avoided 2 weeks after vaccination. Suppose the child has received chickenpox vaccine today, and if it's due for any blood product, then you have to defer that blood product for at least 2 weeks after the date of vaccination. But you can give your inactive vaccine, even rotavirus vaccine and oral polio vaccine can also be given, as because here the immune response is not going to be interfered by the your humoral immunity. Now, these are the doses of the various immunoglobulins and the gap needed for the live vaccine. Now you can see that in the Kawasaki disease, we give a very high dose, like 2 gram per kg of the IVIG. So when this such a large dose is required, then MMR and varicella vaccine, you have to defer it or delay it for the period of 11 months. But if the dose is very low, like in case of hepatitis B immunoglobulin or tetanus immunoglobulin or human rabies, then the vaccine can be given 3 months to 4 months interval after the immunoglobulin product. So it all depends upon the dose of the immunoglobulin. Now HIV is also another special situation. Here it's a T cell defect. It is a T cell defect, and therefore it mainly hamper your intracellular organism immunity. Now in this HIV patient, the live vaccines are contaminated in severe disease, and your CD4 count will help us to find out whether the child is severely immunosuppressed or mild to moderately immunosuppressed. Now here inactive vaccine can also be given, but there is an impaired effectiveness with low CD4 count, loss of prior immunity is there, lack of cell immunity is there. Now you can see that this chart is which is recommended by AEFI and WHO that whenever the BCG can be given if the child is asymptomatic. However, if the baby is symptomatic, then you cannot give BCG. OPV can be given in an asymptomatic child, but not in a symptomatic child. But by and large, in an HIV child, we usually give IPV, and OPV we do not give. Similarly, measles, MMR, and varicella should be given depending on the CD4 count. If the CD4 count is more than 15%, in that case, you can give the vaccine. So HIV is also important special situation where dose modification and schedule modification is required. It all depends upon the CD4 count. Now, in the modern days, there are a number of patients who undergo chemotherapy for the various cancers. So all the vaccines should be completed before the initiation of the chemotherapy. All live vaccines should be avoided at least 2 to 6 months after the chemotherapy. Varicella is very important. So varicella to be given 1 year after stopping the chemotherapy, or you have to find out that when the lymphocyte count is more than 700 and the platelet count is more than 1 lakh, In that case, you can give the varicella vaccine during remission, and immunization can be given during chemotherapy. However, there is decreased immunogenicity, and therefore antibody titers are required after completion of chemotherapy, and booster doses are required when it is indicated. So as far as the chemotherapy is concerned, all live vaccines should be avoided at least for 3 to 6 months, and varicella is a special situation, and it should be given 1 year after the stopping the chemotherapy, looking at the WBC count and the platelet count. Now, as far as the bone marrow transplant is concerned, it is very important that now we are doing lot of bone marrow transplant. So since as far as whenever since the planned event, all vaccines should be completed at least 1 month prior to plan. So the ideal situation is that all the vaccines should be completed 1 to 2 months prior to the bone marrow transplant. Underlying condition itself can be immunocompromised cell, so vaccination is very, very important. Now, as far as the bone marrow is concerned, there is bone marrow transplant is concerned, there is a total marrow ablation. So all the memory cells are lost, and therefore the child becomes immunologically vaccine naive. So all appropriate vaccines should be completed in all the children as if the child is totally unvaccinated and totally naive. So sometimes there may be a condition where child may require a post-exposure disease prophylaxis, and this post-exposure prophylaxis should be given in form of passive immunization, like use of the various immunoglobulins, because the child needs urgent protection. In general, the influenza vaccine should be given yearly in order to start it 6 months after the transplant. Other vaccine can be given 1 year after the transplant, and live vaccine like MMR, MR, and varicella should be given 2 years after the transplant. So as early as you can start the influenza vaccine 6 months after transplant, field vaccine 1 year after transplant, and live vaccine 2 years after the transplant. And remember that child should be considered totally naive, and all the vaccines should be carried out as per the age of the child. As per the solid organ transplant is concerned, like liver transplant or kidney transplant, then in contrast to BMT here, vaccination prior to transplant is of prime importance. So should complete all the immunization prior to transplant in an accelerated manner. Vaccination with live vaccine should be completed at least 4 weeks prior to transplant. MMR and varicella vaccine should be administered at least 6 to 11 months in infant. So usually we give the MMR and varicella, MMR at 9 months, varicella at 12 months, at 15 months. But here, this is a situation where MMR and varicella can be given as early as in an infant up to 6 to 12 months of the age. Now, as per the recipient post-transplant concern, vaccination with in-vaccine vaccine can also recommend 6 months post-transplant. Influenza vaccine can be given as early as 1 to 2 months post-transplant during community outbreak, and boosters for the inactive vaccine should be given as per the schedule when the antibody levels wane. Like hepatitis A and B in liver transplant, we can start 6 months post-transplant, and no live vaccine should be given post-transplant and can be given after 2-3 months after stopping anti-rejection treatment. So as far as solid organ transplant is concerned, I think we have to complete all the vaccine prior to transplant, and the transplant and the vaccination of the donor should also be updated. As far as the various bleeding disorders is concerned, like our hemophilia, they are more prone to hematoma. So preferred route is subcutaneous. Intramuscular dose is to be avoided. You have to apply a firm and sustained pressure for 5 minutes without rubbing it. And aluminum adjuvant vaccines should be avoided while using a subcutaneous dose. And remember that these children often receive various factor replacement therapy, and therefore vaccination should be offered after the factor replacement therapy so that the large hematoma does not happen. So it is very important that we plan our vaccine schedule and the replacement therapy schedule back to back. First, child will receive the replacement therapy, and follow immediately after that, child should be given vaccination. There are certain comorbid situations, like in a child who has got a chronic liver disease. These children must be protected for the hepatitis and hepatitis B, because they may end up into a fulminant encephalopathy. So here, chronic liver disease, the special priority to be hepatitis A, hepatitis B. In a child with chronic liver disease cirrhosis, the seroconversion is also going to be poor. So child will require double doses. Sometimes even boosters are required for hepatitis B, and these children also require annual influenza vaccine. As far as the pulmonary and cardiac disease is concerned, influenza vaccine and pneumococcal vaccine are the priority. For the progressive disease, acellular pertussis is preferred over the whole cell pertussis vaccine. For the chronic disease like nephrotic, vaccine against the capsular organism like pneumococcus, meningococcus, and Hib is very important. For the dialysis patient and for the chronic renal failure, hepatitis B vaccine is required. Here again, additional doses are required, double doses is required, and booster is also required. And for the cochlear transplant, they are more prone for the pneumococcal otitis media. There is increased risk of the meningitis and otitis media, and therefore these children will require a pneumococcal vaccination. There is no evidence that patients undergoing cochlear transplant require MCV vaccine. So they require pneumococcal vaccine is recommended as far as the CDC is concerned. There are rare disorder like primary congenital immunodeficiency. If the child is suffering from primary B or primary T lymphocyte defect or a combined deficiency, then there is abnormal response and less efficacy. The live bacterial and live viral vaccines are contraindicated. Like live bacteria means typhoral, and live vaccine, we all know MMR, OPV, they are contraindicated. Most of the patients who are receiving regular IgV, so contraindications are there. And so it is very important for primary congenital immunodeficiency, primary B and T combined deficiency, there is abnormal response, there is left access there. In only B cell defect, we can give live vaccine like measles and varicella can be given. Inadequate kill vaccine can be given, but the efficacy is going to be inadequate. So we cannot give live bacterial and live viral vaccine as far as T cell defect, B cell defect, and combined deficiency is concerned. As far as complement deficiency is concerned, all vaccines are given and are safe. If there is deficiency of the early C1, C2, C3, C4 complement, the pneumococcal vaccine, meningococcal vaccine, Hib vaccine is very important. For terminal vaccine complement deficiency, that is C5 to C9, very important is a meningococcal vaccine is a priority. Influenza vaccine is also important, prevent the secondary bacterial infection following flu. As per the phagocyte disorder like chronic disease or leukocyte disorder, all live bacterial vaccines are contraindicated. The classic example is typhoid live oral vaccine, which is not available in India. There is typhoral. Live viral vaccine can be given. Even inactive vaccine can also be given. Influenza vaccine is also very, very important. And pneumococcal vaccine is also important. For the pregnancy and lactation, all live vaccines are contraindicated because there is theoretical risk to fetus. Inactive vaccines are safe, but given only if the risk of the disease is more compared to the vaccine side effect. Most vaccine can be given in the immediate postpartum period before the discharge. That is going to be very safe, and all vaccines except yellow fever are safe in the lactating mother. So for the vaccine, especially meant for the pregnancy and lactation will be TD or TDAP, influenza vaccine and COVID vaccine should be given. Rabies vaccine should always be given when indicated. Age is not a bar, and hepatitis B vaccine should be given in pregnancy. And pregnancy is an immune altered situation and not an immunosuppressant. So some special care is required. If you immunize the pregnant woman, I think they can transfer the IgG type, the antibody of the child, and we can protect the newborn from the diseases like influenza and pertussis. So that is about the vaccination for the pregnancy is lactation is concerned. So I think that is the last slide. So I thank the organizer for giving this opportunity. If you have any question, I will be happy to answer that. Thank you so much.
Thank you, sir. Thank you very much for the lucid presentation. Always nice to hear a lecture from Abhay Shah. So, yes, sir, can you stop the sharing of slides? So, there are questions which I will be taking. And even if there are some questions from the last 2 days also, you can take those questions here and we will complete the whole. That is how we will do it. Okay. So there is a question for you, Abhay Shah, sir, that a child had received immunoglobulin 3 months back. Now he wants to go to Kenya. Can he take a yellow fever vaccine? Because you said that there has to be a gap between immunoglobulin and a live vaccine. So a little bit tricky question and always a favorite question of Sanjay Marathe, sir.
So, I think we should outweigh the risk. I think yellow fever is such a disease. Whatever the immunity child gets, you should get it. There is no
Okay.
contraindication.
So the answer goes to Sanjay Marathi sir also. Sir.
Yeah. Because the immunoglobulins which are prepared in India will have no antibodies against the yellow fever.
Because we don't have any disease, yeah. we
Correct.
don't have-
So the countries where there is no yellow fever, if the immunoglobulins are prepared, there can be safely given,
Mm,
and that will protect an individual from the yellow fever.
yeah.
But we have to ensure that the immunoglobulin was produced in India.
Yeah.
In India, yeah. So I
population.
was to come there. So where the product is manufactured.
That
It
is
is
very
from
important.
outside, na, this
Because-
principle will not be
Absolutely.
applied.
Absolutely.
So what
So
is
by
this
and large-
benefit? What is
by
this
and large, we
benefit
should-
of- Yes, Abhishek sir, go ahead.
No, even for the certificate and all this is required. I think so. We at this juncture, I think we have to be practical and we can give it.
So that is a practical outcome out.
Yeah, because we need the certificate, no?
Yeah.
Most of the time, sometimes these immunoglobulins are from China, where yellow fever is not there, I think.
So, and what is the validity of this yellow fever vaccine, Abhishek sir?
Certificate, lifetime now.
Validity.
Yeah.
Huh?
Now it is
Certificate
lifetime.
is previously it was 10 years, now it's
Yeah.
lifetime.
They have changed it to now lifetime. Correct.
Since 2017 or 18, they have changed it,
Absolutely.
lifetime.
Right. One more question to you, Abhishek sir, that the newborn was given hepatitis B immunoglobulin, now went to give BCG, which is a live vaccine.
Immediately, we can give BCG immediately. There is no contrast because BCG is a T cell defect and this immunoglobulin is a humoral antibody. There is no interference. We can give it.
Yeah, but the confusion arises because BCG is a live vaccine, isn't it?
Yeah. Hmm.
So why hepatitis B immunoglobulin does not interfere with BCG?
No, because the BCG is going to work by T cell, not by the B cell. And the immunoglobulin is going to interfere only with the B cell response, not the T cell response.
A question to Sanjay Marathi sir.
Yeah.
Anything specific about rituximab, because there was quite much interest about rituximab and what should be the vaccination guidelines after that?
It's a very interesting question, Sagar. And we have included this in our question as one of the, I think, white paper or something. The rituximab, if it is given as a treatment protocol, it is almost like doing a bone marrow transplant. So, if you follow the Australian guidelines for rituximab, there was an excellent, I think we have published it somewhere. After that, almost the immunity against the all vaccines has gone. And it should be considered as a knife and should be given all the vaccines again. But the only question is, now which is discussed, suppose one dose of rituximab is given to somebody. So it has been seen that the antibody titers and the immunoglobulin levels have gone to such a low level, especially with the repeated doses of rituximab. Whether it holds true for one dose is not very sure. But if the rituximab is used as a treatment protocol in one of the situations, then that child should be considered as almost like a bone marrow transplant and should be given all the vaccines. I think we have published in ACVIP because I have only written this topic.
And secondly, if there is a
There was a
very
question on rabies. Yes,
One
Abhishek
minute.
sir.
there is also same corollary is there. If the child has a very high dose of chemotherapy for any cancer treatment, again, there should also be considered as a marrow ablated and can be given is considered as a knife. So it implies same to rituximab.
But many times as a pediatrician, we don't know much about drugs of chemotherapy, which are the types of drugs. And there is always this confusion. So if we don't know what exactly was the drug, what exactly was this effect, how was the mechanism, it will be always be safe to wait for 3 to 6 months as a general principle. There was a question on rabies, Sanjay Marathi sir.
Yeah.
Why exactly was the 5th dose of rabies vaccine removed by WHO?
See, if you go through the studies, it has been seen that there is no change in the antibody titers after the 4th dose and rather it was for the 6th dose. Basically, this was initially with the 6th dose. Now, with the 4th dose, there is enough evidence. If you see from 2004 from CDC and WHO recent position paper, what they have seen, the studies from India, studies from Nepal, studies from America. And I think the 4th study is from Costa Rica or somewhere. All the studies with good number of people they have seen, not a single person has died after 14th day of anti-rabies vaccination. And whatever the mortality was seen, was seen either because of the inadequate doses given or the immunoglobulin was not given at the category 3. So they have seen in none of the patients, including in the developing countries like India and Nepal, because they have seen many people have received only 4 doses and they have not come for the 5th doses. So the protection offered by even 4 doses is equivalent to 5 doses. So now CDC says, the WHO says, even the ACVIP has said that with this evidence, the more and more compliance will be there. Otherwise, the people will not turn up for the 5th dose and all that. So they are now trying to shorten the number of doses for the better compliance and the better equally good protection. So 4 doses versus the 5 doses.
You are mute.
I think, sir, we lost sir here. I think sir has clarified that even if we give 4 doses or 5 doses, there is a plateau level above which the anti-rabies antibodies do not rise. The 5th dose was removed. Dr. Priyali, madam, a question for you. There was a suspicion of anaphylaxis and therefore adrenaline was given. But later on, it turned out that the episode was not anaphylaxis. So what will be side effects, and did I do a major mistake by giving adrenaline?
No, I would say that you were a little apprehensive, so you gave adrenaline, but you did not make a mistake if you suspected anaphylaxis. I would advise you to keep that chart of anaphylaxis which we have shown you, and for the next time you will be wiser off. You can always refer to that chart. As I said, if 2 systems are affected, I don't know what the signs and symptoms were because you suspected it. That you being a medico, I would say that you would know whether 2 systems were affected or not. If they are, then it was anaphylaxis. And if you've given adrenaline, it was a good thing. But later on, if you find you cannot undo the adrenaline, so you just need to keep a close watch. That's it.
What are the side effects of adrenaline? Let us say if I have given adrenaline, at the most, what is going to happen because of adrenaline?
It may cause
Maybe
tachycardia, sir.
I think it's a very safe drug for 1 dose of intramuscular adrenaline. Worst come worst, you can have little tachycardia and uncomfortable feeling for some time.
Tachycardia. That's it. So you need to keep a close observation, and that is all.
Tachycardia and palpitations may be there. And later on, there may be slight hypotension. Adrenaline initially vasoconstriction will be there. Later on, some skeletal muscle dilatation will be there. Little hypotension may be there with the patient. But initially, it is a tachycardia and palpitation.
So some tachycardia, some headache, some tremors, some pallor, some anxiety. That is what is going to happen. Other than that, nothing happens. Why we don't give adrenaline subcutaneously or IV in anaphylaxis? Priyali, madam. Priyali, madam, why we don't give adrenaline subcutaneously or IV?
The IM absorption is much better than the this thing. And we don't want an immediate rapid action of adrenaline. We want it to be a little delayed and cover. So that is why we give IMs.
So basically, and in anaphylaxis, the patient is in shock. So when the patient is in shock,
we don't want rapid vasoconstriction.
We are not expecting the adrenaline to get absorbed from subcutaneous space. And as far as IV is concerned, if the patient has already received 2 or 3 doses of adrenaline, the patient is in ICU on full support, taking IV fluids, intubated. In that cases, yes, you can give adrenaline IV, but not in routine cases.
So that is when there is a need for inotropes.
Sagar, the take-home message for all of us is do not wait for the IV access. Because immediately what you are supposed to give is an intramuscular. Then think of putting an IV line and do it. After 2-3 doses, as you said, you can give IV. But must be having monitoring of the patient, cardiac monitoring, and a facility for an intensive care management. Sometimes you can have arrhythmias because of this.
Very correct. So a question for Surendranath, sir.
Yes,
sir. There are 2 quadrivalent HPV vaccine. One is a Cervavac and another is a Gardasil 4. But now we know that Cervavac is a very cheap vaccine, isn't it? So hardly half the cost. So can I interchange it?
It's a hypothetical question because we don't have any data whether interchangeability will affect any immunogenicity. I think as far as the antigen structure is concerned, both the quadrivalent vaccines have the same strengths like 6, 11 and 16 and 18. So I think there is no problem in interchanging the vaccine because same strains are there.
Because there are same strains. So I also think that practically, yes, you can interchange.
You can.
Now there are single dose also of Cervavac which are available, because few months back we only had the vial with 2 doses, but now a single dose Cervavac is also available for office practice. Surendranath sir, do you insist on taking Gardasil 9 to a patient? I'll tell you one of the episodes. I started explaining Gardasil 9 to my patient, but when I told him about the cost, he said that he will think. He went away home, but he never came back. So now I have a feeling in mind that I have missed the chance to vaccinate the child with at least a Gardasil 4 or Cervavac, rather than unnecessarily insisting on Gardasil 9. I have that guilty feeling in my mind. What is your take on this, and how do you go ahead in your office practice?
In my practice, what I will tell, I will give the option to the parents. I'll tell the cost, I'll tell the coverage of the serotypes, whatever serotypes are covered by the vaccine. And I give option to the parents whether they want to take a quadrivalent vaccine or a nanovalent vaccine. So once you give the option, they will decide. Usually they don't go back. Somebody may decide on a quadrivalent vaccine, somebody may decide on a monovalent vaccine. So I think the option should be given to the parents by explaining the coverage part of the vaccine. And the cost also we can explain. And most of the times what happens is, if you insist, if you say this is the best vaccine, usually the patient will say that he will come after some time. In that process, you may lose the track of the patient. Another thing is, most of the times Gardasil or whatever it is, HPV vaccine should be offered along with the Tdap vaccine. Otherwise, what happens, once they take Tdap, they will not come for the HPV vaccine. Both vaccines should be given simultaneously up to 10 years of age to increase the coverage of HPV. This is how I counsel the parents during giving HPV vaccine.
Marathi sir, you want to add something?
So when the
I think
nonavalent had not come, see, Dr. Sagar, when the nonavalent had not come and the quadrivac was not given to, not sort of advised for male children, they were always asking for it. Now that the nonavalent has come and it is now can be advised for male children,
Yes.
the costs are so prohibitive that they are running away.
No, Cervavac is also recommended as a gender neutral vaccine. So now there is no risk. We can advise Cervavac as gender neutral. What I normally do, I explain them why it is a must vaccine. And then tell you that this is a cost difference. But what is more important, you should give whatever vaccine you can afford. I will never say you go for nonavalent or quadrivalent.
Yes.
You must give the vaccine, that is more important. Financially, you decide which one you want. Scientifically, I have explained you. Financially, you decide. But give a vaccine. So now with the difference of 2,000 rupees and 11,000 rupees, many of them might prefer the Cervavac, which is a good vaccine. But so there is nothing wrong in that.
So one-to-one discussion is the best way out. And rest of things are not in our hand. That is what is.
Yeah.
Marathi sir, what is this Flucelvax and flu block vaccines?
Yes, sir.
Can you repeat?
It is a recombinant vaccine. With Flucel is a recombinant vaccine. In fact, it doesn't contain any egg antigen in the vaccine, so it can be given as a whoever is having a severe egg allergy, we can go for this vaccine.
I got confused, and I think it is not available here. It is available only in the
it is
Western.
not available.
Yeah, I did not get your point exactly. Okay.
So basically, I wanted to ask is what is this egg adaptation and what is the importance of cell culture vaccine in influenza vaccines? Marathi sir.
See, the importance will be basically that most of the vaccines which are, so flu vaccines are having some part of the albumin which is included in that. And especially with the allergy to the egg, which is very common in the Western world, what they are trying to do is that the minimum quantity of the egg in the vaccine will be safer for them.
So basically also, and that there was some issue of egg adoption because the immunity against some serotypes was very low in the egg-based vaccine. So
Yeah.
they started producing the cell culture-based vaccine.
Yeah.
And this Flucelvax and Flublok are the cell culture vaccines which are available in Western world. So, but they are not available in India, just a part of a
But
sensitization for vaccine.
surprisingly, Sagar, their composition is also different.
A little bit, but
Yeah,
yes.
that is very surprising because if you read the CDC guidelines, you will see the composition slightly different in both.
So the recommendation for egg-based vaccine and recommendation for a cell culture vaccine, the WHO also gives a different recommendation.
Correct.
So Marathi sir, this child has come in the month of February for flu vaccine.
Okay.
Now you know that in the month of March, April, Southern Hemisphere is going to come. So you have two options. One is you can postpone the vaccine till February, March, April, or you can give it in February. What do you do in your private practice?
I am very clear. If he is coming for a priming of the doses for the first time, I will not wait. I will give whatever the strength is available. Whether it is by that time, usually it is the northern hemisphere strain which is available. So for a child who is coming for the first time against the flu, I will give it. I might give it one more dose during that year, around say August, September, to cover him for that year because the protection will be only for 6 to 8 months, and this child is likely to get exposed by November, December. But if this child has already received 2 doses before, and if he has come for an annual vaccination, I will discuss with the parents saying that a new vaccine is coming in next 1 month. If we can wait, it will be benefited to the maximum. So if you agree, we postpone it to April. As soon as the vaccine will come, I will inform you, you take the new one.
So if he has already taken vaccine, then his as such vaccine was due in April month only.
Correct.
So no issue. But as you have said that it was a priming dose, he has not taken his series or he has taken only single dose. Better to give vaccine, do not reject any patient. You give vaccine, you can repeat one more in the after 3 months, there is no issue
Absolutely.
about that. Yes, very true. Surendranath sir, do you want to add some questions? Or should we wind up? Unmute
Sir,
yourself.
you are muted. Unmute, please.
Is there any questions on the chat box? No.
If there are any questions from your side, we can take.
One question I just wanted to know, there is recommendation for the MMR varicella vaccine as far as IV, IgG is concerned. So do we have such recommendation for hepatitis A vaccine also post IV, IgG administration to any child?
Yes, he would say live hepatitis.
You are using a live hepatitis A vaccine.
Live hepatitis A, the same.
Same.
Not for the killed one. Not for the killed one.
But nothing is mentioned in literature, but the principle remains the same. I got your point.
It is the same.
Yeah.
Because always it is mentioned MMR varicella only regarding the IV, IgG.
Because Americans do not have hepatitis A live vaccine in their paper.
So the literature does not mention that.
And major
Chinese, you should read the Chinese book.
And majority of these recommendations are mainly from the experience based. They are not evidence based. All these special situations, they are from the elaborated from the experts' opinion. Hardly there are many studies out there.
One question is
remaining. Abhay Shah sir, can MMR and BCG be given together?
Yes, we can give it 100%.
There was some confusion earlier that it cannot be given together.
Previously it was there, but now it is. Anyway, BCG इतना कोई late देते भी नहीं है. Usually by all is over. But even if you wait for 9 months or 15 months, we can give it immediately, simultaneously.
Abhay sir, one more question, practical question. So nephrotic syndrome is diagnosed today, let us say. The child has not received.
You have muted yourself. Surendranath sir, you have muted.
So you may give the vaccine before starting the steroid.
No, please repeat. The child has started nephrotic syndrome steroid today.
Nephrotic syndrome was diagnosed today, let us say. Child has not received any pneumococcal conjugate vaccine and varicella vaccine.
Yeah.
So can we give the vaccine before starting the steroid? Suppose if you give
Yes.
the vaccine,
Yes. We can start it.
can we start the steroids after 2 days?
Immunosuppression will take place after certain duration. On a first day, it is not. It will not hamper immunity. We can give it.
Preferably
So
2 weeks
varicella
prior
also
to
can-
starting the steroids.
Yeah.
So I will like to add one thing, that as far as skilled vaccine, you can give it even during the steroids also.
No,
That
MMR
is
is
not
very
the
slow.
issue. Now, preferably if you can give before starting steroid, let us say like pneumococcal vaccine, vaccines against capsulated organism, that will be more better. No, as far as the live vaccines is concerned, let us say varicella vaccine, the immunity starts after 4 to 6 weeks. Okay. So as a general principle, we say that after giving live vaccine, don't give immunoglobulin within 14 days. If you give a immunoglobulin within 14 days, the varicella vaccine will be considered as invalid and you will have to repeat the vaccine. So in this situation also, now there is nothing like this written anywhere in the literature. But if I have given a varicella vaccine and after 3-4 days I start steroids, but after 2 weeks now it is going to interfere with the vaccine response of varicella vaccine, to be very sure. So this will be a problem, and it will be better if you repeat varicella vaccine after 1 month after stopping the steroid. That is what I will recommend if I am being asked.
But
No,
if
no,
we
but,
can delay,
there is-
if we can delay the steroids by 15 days, then it is worthwhile giving us
That
chickenpox
does not
vaccine.
happen because the patient has so much worry.
Yes,
syndrome.
correct, absolutely. See, many times I have seen, usually they will see urinary tract infection to be treated and then start with the steroids. Then we'll have to ask whether you want to start with the steroids within next 40 days. Then only we should give PCV 30.
So nephrotic syndrome treatment, we don't postpone just because vaccination is pending.
No,
If
no, no.
at all the person who is taking
If the
steroid is
doctor treating is thinking of giving after 2 weeks.
he can do that.
Absolutely.
Okay, sir. I think we have concluded the session. No questions, no? I think there are no questions.
And it was a very good discussion. And
Thank you,
I
sir.
think,
It was a pleasure always.
so, Surendranath sir, you want to add some words from your side? You want to say something?
So after 3 days, definitely it is one of the excellent module, the way it has been prepared. And the division of 2 hours is excellent so that people can be more receptive rather than a continuous vaccinology session. And it is more practical and practice oriented. And most of the pediatricians will definitely benefit from this module. So the way it has been structured is very simple, easily understandable. I feel that it is definitely going to help to the great way to the practitioners. So our office bearers are there.
No. Yeah. So I would first like to thank Dr. Yashwant Rao sir, President IIP Telangana, Dr. Vamshi sir, IIP Telangana Secretary, Dr. Lakshman sir, IIP TCB President, Dr. Sridhar sir, IIP TCB Secretary, for taking all the efforts because of which this module was conducted very successfully. Special thanks to Dr. Surendranath sir for coordinating. Thank you, sir. Thank you so much. And thank you to all the faculties. Today's faculties also, Dr. Abhay Shah sir, Dr. Piali madam, Dr. Sanjay Marathi sir, for sparing their valuable time, and all the faculties who were there in the 3-day session, because of whom this session went on very, very well. I thank Central IIP office bearers also for all their constant support in this program. And I once again thank Sanofi for giving a scientific grant to Central IIP for conduction of this module throughout the country in different states. So thank you, Dr. Piali madam also. She is vice president of our zone. Thank you very much. And hats off to our dedications also. So over to you, Dr. Vamshi sir, for the concluding remarks.
Sir, special thanks, as Dr. Surendranath sir has well said, that it is very practically oriented. I totally agree. And I thank my president, Upendra Kinjwadekar sir, Vinit Saxena and his team, and Basuraj sir, who is incoming president, and Vijay Balai sir, and all other faculties, Piali Bhattacharya madam, Abhaisha sir, and yourself sir, Sagar sir, and Marathi sir. Thank you so much for giving an insight. This is a wonderful program. I think it should reach all. Somebody was also asking if the recording is available. Yes, it is available on the AEFI platform, if I'm right. And thank you so much for giving this opportunity to Telangana state to be a partner of it, to participate. Thank you so much, sir. Thank you for giving this opportunity on behalf of PATS and TCB.
Thank you,
Thank
and
you,
see you
thank you
all.
so much. Thank you, everyone. See you all.
Thank
And
you,
we had a
everybody.
wonderful time.
Thank you. It was a wonderful.
Yeah. Thank you,
Thank
sir.
you. Thank you. Bye, everybody.
Thank you once again.
Okay, sir, bye.
Bye, sir.